Welcome back to another episode of the Braun Performance and Rehab Podcast, powered by ISOFIT and Firefly Recovery. ISOFIT is my go-to for all things isometric strength training. For more on ISOFIT, be sure to check out isofit.com. Episodes like this are made possible by Firefly, the official recovery provider of the Braun Performance and Rehab Podcast. For more on Firefly, be sure to check out recoveryfirefly.com. This episode is powered by Dr. Ray Gorman, founder of Engage Movement. Learn how to boost your income without relying on sessions. Get a free training on the blended practice model by following at Ray Gorman DPT on Instagram. Joining me today on the podcast is Steph Allen. I had the pleasure of meeting Steph back in February at APTA, and I really appreciate all the amazing work she's doing in the space that way, especially around the ACL and just elevating the state of rehab in general. And we discuss all of that and more in this episode today. This was an amazing conversation with Steph. Really appreciate her time and highly recommend you check out her page and all of the amazing stuff she's doing in the space if you haven't already. Enjoy. Steph, welcome to the podcast. I'm super excited to work with you today, and huge shout out to our mutual friend Katrina for helping us get connected. For people who aren't familiar with you and all the incredible work that you've been doing in the clinical space, in particular surrounding the complex knee injury, would you mind filling people in a little bit about who you are and all the great work that you've been doing?
Yeah, I appreciate that. And 100% shout out to Katrina. Miss you, Katrina. Um, yeah, I'm excited to be here. Crazy to think about it, but I've been a PT for 11 going on 12 years now. It's like kind of wild to think about. I feel like I just finished residency and was like doing travel PT and like not really knowing what I was doing. For all you people out there, don't worry. We know enough of what we're doing when we're new grads that you're fine. But yeah, so I mean, it's a much longer story, but essentially I did a residency, then did travel PT for a couple of years. Then I was in Boston for almost 7 years at a really cool private owned sports ortho clinic. And really that is where I kind of like dove deep, honed my skills, got a lot of practice with mostly ACL, but really all knee injuries. And was lucky that our set up at that clinic, although, moderate volume, not like a super crazy high volume, but, probably middle of the road. But in general, how we were able to treat was supported in terms of being able to deliver, high value care. And so I got a lot of practice, a lot of reps at that clinic in Boston. And then, life and career is funny. There was just some things that I needed to change, and namely, when most of your caseload is an ACL injury or some other, complex or longer term rehab situation of the knee, I was feeling a little bit like my hands were tied in terms of I was programming for all these people outside of their sessions, knowing that, the most they were seeing me was twice a week. They were needing to do so much more, right? And we'll probably get into some of that in terms of, how the rehab process for really highly active people probably needs to look a little different after these injuries. So it was just a real quick, I would call it burnout, but really just kind of like, programming for people outside of sessions, also doing progress notes and regular notes. And I couldn't bring all of me to the table most days, and I didn't like that. So I ended up going down to part-time, and then, wouldn't have guessed it, but ended up starting my own thing virtually. That's been almost 4 years now. And with some prospects, we're moving back generally to the Boston area in the next year and hoping to try to do something hybrid. So that's on the horizon, meaning like a mix of virtual and in person. Don't know exactly what that looks like yet, but yeah, that's where I'm at currently, and just, continuing to try to learn.
Yeah, congratulations on the future return to Boston, and what an
Thank you.
incredible journey and just a wealth of knowledge and experience you have from your years as a clinician that way. And it's interesting because you kind of hinted at this issue that we see in the clinical practice space, especially with athletes that are facing some of these complex knee injuries like ACL or ACL and meniscus injury that take 9, 12, sometimes even longer from a month standpoint to get back to where they want to be, where, maybe they don't need to see their PT on a regular basis anymore, right? But there's multiple sides to this story. There's the patient who is frustrated by the fact that they're only able to see their PT once or twice a week, or maybe they've got a whole lot of hidden costs that they have to deal with from an insurance standpoint. I just spent an hour this morning actually dealing with that with someone where she got hit with some surprise bills from almost 2 years ago, which is just insanity to think about, but it happens more often than I think we realize. So we've got this issue for the patient not getting access to the care that they need and getting hit with some surprise bills. And oh, by the way, even if they are, authorized to get care and they're seeing care from a PT 3 times a week, there's then the question of, is the PT experienced in working with this kind of injury? Because unfortunately, our outcomes, regardless of what level of athlete you are, professional all the way down to middle school, high school, are not as good as they should be, in my opinion. And I have no issue throwing our profession under the bus for this, but we look at that 1 in 3 injured ACL patients that don't return to sport, and I just can't help but wonder if that number should be a little bit lower, if that number should be a little bit better, because maybe, clinicians, maybe we need to look ourselves in the mirror sometimes and say, what could we be doing different or what could we be doing better? But in defense of the clinician, as you mentioned, sometimes you've got a lot of patients to work with. You have a lot of things going on, and it can be very, very difficult to try and, pour from a cup that's full, if you will, when you're constantly emptying your cup over and over and over again, balancing the demands of clinical practice and all these other life demands that I feel like are not discussed enough that way. So we kind of find ourselves in this weird problem area for the patient who's faced a complex knee injury where there's a lot that they need, but unfortunately, it seems like the current system that we have in place doesn't necessarily provide the best for them or provide what's necessary to get them all the way back to return to sport the majority of the time. And maybe I'm crazy for making those claims, but I just feel like that's kind of the current state of, our healthcare system and providing for the athlete following a complex knee injury that way.
Yeah, I think, and it's not only a complex knee injury. There's definitely other, I think, potentially more chronic injuries as well. And then it's interesting, they almost kind of, I think, not to categorize an ACL injury or a complex knee injury as chronic, but technically, if you're going by the definition of chronic, the amount of time that it takes to, you know, by definition, fully recover, that's a chronic issue. There are multiple phases. It's almost like, in my mind, a chronic issue that you just know going in is going to be chronic, unlike, an ankle sprain or something where you've had some naggy shoulder pain that you go in for and you're not really sure how long it'll take to sort of improve. Some people, things end up being more chronic, others not. Like this is a situation where to your point, like you can pretty much guarantee that it's going to be at least 9 to 12 months, especially based on research right now. And that is without any setbacks, without any like hiccups or anything, and often with a plan and a provider that, is experienced because it just does seem to take that long. And, that's even aside from different grafts, because different grafts tend to take a little bit longer. It's probably a whole different conversation. But yes, to your point, I think that unfortunately, it's twofold, at least in my experience. The system itself, again, I was lucky to be in a place that really allowed me to treat how I believed, but it was still every 30-minute sessions. And a lot of times I was just needing to see 2 to 3 kids at a time after school, which is like, okay, that and it was, in some ways good. Like they could do some things together depending on what stage they were at and whatnot. But that combined with the amount of space and equipment we had, that there was definitely some limitations there. And then again, I knew that they needed to be doing most of these at that time were high school kids, right? So they're going back to a sport where or we are working to try to prepare them to be doing something sport related, very active, probably 6 days a week. And if they spend a year doing things twice a week, and maybe one other day, if I try to hold them accountable for one other day on their own, there's a big gap there, right? So I was running into that programming for people outside their sessions, like I was saying. And so that's in the case of a provider that is sort of specialized in that area and knows what they need. In a lot of cases, especially at higher volume places, they're seeing 15, 20 people a day, maybe. Like, that's not an exaggeration. So there's no way that that PT as a human has the bandwidth, nor should they if they want to take care of themselves and actually like eat dinner and sleep between shifts, that they're going to like write programs and be able to kind of like correspond via email with people between sessions. So definitely system is one thing. I think the other issue is, we're generalists when we leave school. I can't recall diving deeper than the anatomy and healing timeframes of ACL injuries in actual like didactic work in school. There's just not, there's not really time for it because we need to learn all the things, which I totally understand. But similarly to how I would not feel comfortable with somebody after a finger tendon uh surgery, you tend to, if you have an interest in an area, sort of like niche down, really dive deep, understand everything about it that you can. And that's just not necessarily the norm with anybody at a general sports ortho clinic. And so I think that people are going to the place that their insurance covers and where their surgeon sends them, but it isn't always necessarily going to be the best fit for them. And people don't realize that they have what we call it health literacy or whatever, or just doctor patient dynamics. They don't necessarily have the knowledge and maybe confidence to basically shop around for a provider.
Yeah, and it's interesting you say that about shopping around for a provider because I've noticed patients more and more are doing that with surgeons. They're getting second opinions, sometimes even third opinions. And I would love to see something similar from a PT standpoint or a rehab standpoint. I would love to see an evolution in the system where it's almost like the patient gets like almost like a Q&A kind of session with the PT almost like, hey, what's your experience working with patients that have had similar injury to mine or the same injury as mine? What kind of outcomes have you seen from the surgeon that I've picked that way? Do you two work closely together? Like there's so many different factors to consider there, but ultimately it becomes a question of how do we reach the people who possibly don't even know they need to be reached and, are just kind of following the advice that's given to them and doing what they're told. And then, unfortunately finding themselves in a very difficult situation later down the line that way. And I think ultimately, the more we raise the floor for everyone and kind of raise that bottom line standard of what we're looking for, the better it's going to be for everyone involved that way. And, I know you talk about this all the time, and I see you post about it all the time as well. There's a lot of common trends that I think we see missing in athletes and patients who have underwent knee injuries or even injuries in other areas, like you mentioned, that just seem to be common themes that come up over and over and over again. And it's like, hey, if nothing else, maybe we could start here. Maybe we could start with the big rocks in this jar of life instead of arguing over little small details like the sand in the jar. Let's tackle some big rocks if nothing else. And, at least from one of the things that I've seen from a lot of athletes who struggle mid to late stage ACL in particular, a lot of them just do not own knee extension, whether that's, not getting full extension range of motion back or not getting good knee extension strength back. Regardless of what it is, there's some kind of issue that ensues with knee extension. And I know you mentioned different graft types, and that seems to be regardless of graft type, quad, BTB, whatever. The quad is very difficult to bring back. So, if nothing else, I think that it'd be awesome to see our standard and framework kind of evolve in a way that says, hey, look, at the minimum, we need to make sure that we're getting people back to a point where they have full range of motion equal between the left and the right. And they need to have really, really, really good strength and not just, oh, well, it feels strong to my hand. Like, I would love it if we could find a way to evolve that into something a little bit more objective, if you will. Not to say it's not objective, but I would say it's just a little bit inconsistent between what you might say is strong versus what I might say is strong. And I think the more that we kind of have the conversation around that baseline framework and elevating the floor for everyone, the better we're going to see our outcomes get across the board.
Yeah, I do think that, you mentioned a couple of questions that people can ask in terms of when they're kind of shopping around. I think the analogy or the comparison of, we don't think twice about getting a second opinion with a surgeon, like what's different. In fact, I would, argue it would be more important to get a couple of opinions with the PT because they're going to be spending all the time with you. So yes, I definitely agree with that. I think that the one of the other things it could double as a question that you ask as well, but in terms of raising that floor and kind of having, you know, I think of certain things being sort of bare minimum in terms of bare minimum necessities, essentially, for if you are going to consistently, if you are a clinic that is going to consistently see post-op patients, particularly post-op knee injuries that are going to be returning back to any form of active lifestyle, you need a way to objectively test their strength. And that doesn't mean that you need to go out and buy a huge isokinetic machine that's like 50 grand. You can buy a Tindeck force gauge that's $200. It was $200 like a couple of years ago. But either way, like something very, in terms of like a clinic expense, very affordable business write-off. And having either a clinician that works there that knows or have somebody come in to do some sort of it's very user-friendly type of thing. Most clinics have something sturdy enough to set it up on. That to me is like, to your point, it's you literally, I feel strongly enough about it to say that it's like, well, borderline malpractice to be progressing somebody through ACL rehab without knowing what their quad and hamstring torque to body weight ratio and LSI, limb symmetry are. Like it's just it's so accessible now, it's like almost not excusable, if that makes sense.
It makes a lot of sense. And I mean, I completely agree with your point, right? Like, before you progress someone to the next stage, it would make sense to have them earn that right to progress. And I almost think about it, this is probably a terrible analogy, but I think about it very similar to how we look at like the school system, right? Like you don't just jump into PT school and go right into, the most advanced courses, the 800 level courses day one. You earn the right to get there. You take your general biology and your general physics, and if you're like me, you curse out every single day of it because what do I need to know about that stuff to be a PT? But ultimately, you put your time in and you put the work in. There's a lot of checkpoints along the way to make sure that you've made the progress that you need in order to earn that right to progress. Now, obviously, everyone's going to debate on what that correct assessment is and if it's actually telling you what you need to know. But we could have that conversation a separate time. But in general, I think there's something to be said about having that phased progress or that phased process that has checkpoints along the way where you stop, you pause, you test some stuff, and you say, are we where we want to be? Are we where we need to be? Are we good to progress to the next level? Or do we maybe need to stay here a little bit longer and earn that right to progress later on?
Yeah, I mean, we refer to it as like criteria-based progressions versus timeline. Unfortunately, there's still a pretty pervasive sort of societal and also in the medical field, like expectation that like I'm going to run at 12 weeks and I'm going to start sports stuff at 6 months. And some people can do that. I can tell you from working pretty solely with almost all ACL and knee injuries for the last, I don't know, at least 6 years, probably more than that. Um, it's rare. And I think if people had the expectation of kind of more what you were alluding to in terms of, okay, I'm going to work my butt off in each stage at a certain time frame. We're going to test some things to see exactly where I am. numbers don't lie, right? So like if the numbers are, not necessarily where we need them to be, then it doesn't necessarily mean that we can't progress in some other ways, but in certain areas, let's say it's strength, let's say it's range of motion, whatever, we got to kind of stay at this level a little bit, kind of work, side to side or laterally versus increasing anything. And then you basically kind of like there then earn the right or the milestone or checkpoint to continue. And that in and of itself, though it sounds super annoying, I try to explain to people like I'm a big expectation setting person because I think a lot of people go into this injury, let's say either whether they had the injury themselves or somebody else that they know has had it, or they know nothing about it, but then they do a huge Google dive right when they get injured, as I probably would too if I didn't know. And then they go in again now with some biases. Everyone does, or some expectations. And a lot of times those expectations are not going to be conducive to them having a real good time mentally because they're not realistic. So unfortunately, that does oftentimes fall on us to like reset those expectations, make sure everybody's on the same page. But, that whole process of testing, seeing where we're at, modify, the testing is just as much for us as well. We need to tweak the programming based on that and make sure like, okay, when we get into some later stage, maybe like rate of force development is really, not coming along for whatever reason. Let's revisit that and see where we can maybe make a greater focus of that in the programming. Um, so, like being able to see the testing as like, this is literally just information that tells us where to go. It doesn't mean I'm failing. It doesn't mean I'm, and it, it does kind of dictate your pace a little bit as it should. I think if it was seen a little bit more in that light versus, a test you have to pass and it tells you what kind of person or athlete you are. And a lot of times people are tested and then the clinician or even surgeon will kind of give a little like wiggle room and still allow them to continue to do stuff. If you let that happen once, then the testing later on, it just doesn't hold the same clout for the person. And then a lot of times people they end up being cleared probably sooner because they're like close enough. And that is a whole other reason in turn. Like there's many reasons why I think the re-injury rate is really high, but that's another one that I don't think people talk about a lot.
No, 100%. And you bring up such an interesting point too, in the sense that the testing can be just as much for the clinician as it is the athlete, as you mentioned. And I think that's something else that is not discussed enough is no one gets it right 100% of the time. No one has every answer for every person every time. Everyone's a little bit unique and a little bit different, and how I might, go about loading one person's quad might be different than the next one, for example. So we can't just use the same things and expect it to work for every single person that walks through our doors that way. We have to add that individualization element to it. And sometimes we have to, adjust as we go and realize that, hey, maybe this exercise isn't producing the response I want to and kind of course correct ourselves. But to your point, the more you test, regularly, the more you're going to kind of be able to kind of assess those things in the moment, right? If you don't do any kind of testing on knee extension, for example, until 9 months out, then you could have potentially prevented a huge strength deficit if you tested maybe 4 to 6 months out and caught it a little bit earlier instead of getting that far out and testing for the first time. And I think it makes the decision process a little bit more easier when it does come time to talk about return to sport or return to play, right? Like instead of it being just one snapshot in time, maybe instead we kind of build it out as a continuum, a progression, and we're able to get data points that show, hey, this is where we were, this is where we need to be, and now we've met that, end goal of where we need to be, and here's how we got there, right? You're almost able to map it out and look at the person that you're working with almost like their own case study and kind of create this like N=1 research on their own case that way. And I think it's really, really powerful and impactful to do that kind of stuff. But as we mentioned, there's a lot of issues in the space, but there's also a lot of people, such as yourself and your team that way, they're doing phenomenal work and solving a lot of these issues and having really great outcomes working with people, oftentimes not even getting to put hands on them and getting really good outcomes as well, which I think blows a lot of clinicians' minds because they feel like they need to see it in person or they need to put their hands on someone in order to tell that, they're getting progress. But you're able to do it without seeing that person in person a lot of the time. I'd be interested to hear more about that. How did you go about transitioning from that in-person to virtual-based care, if you will? And how have you been able to, meet all these different criterion and develop a framework that is effective for you and your team that way when you're oftentimes not even seeing a person in person?
Yeah, I mean, to be honest, I was without like sort of unknowingly already doing it a little bit when I was in the clinic. I was programming for people with like Excel sheets and checking, like, aside, the only thing that really wasn't happening that happens now with like through ACL Resolve, like through the business, is like video feedback. That was pretty much the only thing that wasn't happening. And obviously, we have a lot more systems and accountability built in now, over the last 4 years that the systems put in place really do help a lot with that. But I think for me, it was like, other than kind of like the first post-op visit and maybe the first couple of weeks, and sometimes not even every session, was I actually doing anything with my hands? One of the reasons being, especially if we're just taking ACL, for instance, you have the injury itself, which is trauma to the joint, then lots of swelling, however long that you're doing, ideally prehab. But between injury and surgery, there's lots of swelling. You're trying to get range of motion back. You're trying to get the quad working, like going into surgery in the best shape that you can. Then the surgery is another insult to the joint. Again, another inflammatory process, rightfully so, because it needs to go in and heal everything. Potentially, it used to be also that they would use a femoral nerve block in turn for pain control. They're largely getting away from that and using either adductor or some other more local, less intense anesthetic so that you weren't also getting the femoral nerve anesthetized that innervates all of your quads. So that essentially was a third insult to the knee and the quads. And then after surgery, you're trying to, depending on the situation, sometimes people were trying to like crank into extension and flexion. Like a lot of people looked at Neymar's rehab on Instagram, which was like comical because it was pretty much the quintessential everything that you should not do. And so all of that to say, like I'll land the plane here, but like that knee is so hot oftentimes and inflamed in the beginning. If I'm trying to manipulate it past really what it's kind of willing to um, cooperate during a 1 hour session, maybe like they may be there with me for 1 hour, but I'm really only one-on-one for 30 minutes. Um, we can better use our time. So essentially, what I found myself doing a ton of was like educating of like, okay, I will show you how to do patellar mobs. I'll show you how to set up a heel prop because what's going to need to happen is this is going to need to be a low and slow thing. You need to gently nudge that knee and show it that extension is okay. You need to nudge into flexion. You should not be cranking on it because what your body will do, it already thinks that this knee is there's a catastrophe here and it doesn't want to the nervous system is just saying like I don't want to load this thing. I don't want to move it. We need to protect. We need to basically seize up. It's something Eric Meta talks a lot about. He's one of my biggest mentors and like your job is to basically like give it lots of inputs during the day like hey, we're going to like settle into extension here. We're going to, because it's going to backfire on you. So essentially that coupled with the fact that like okay, when I realized in practice what I was doing with them so much was like showing them what to do and how much to do it at home. And then, stim, definitely some hands-on where needed. Some people who were super swollen, we could elevate and do like some soft tissue. That was not ruled out for sure. Um, but a lot of the people that we see virtually, at least in the beginning, we do also recommend having a person in person, even if it's just once a week or once every other week in the first couple of months for those types of things, monitor for infection, anything like that. But I realized that I was doing like pretty much no hands-on. And so then essentially when we started to build out what early phases could look like virtually, and again, not everybody's comfortable with it, it's totally fine. Um, I have a whole instruction thing in terms of how to use stim and a suggestion for one that's affordable to use at home. We have suggestions for compression sleeves. We have suggestions for BFR cuffs, like things that in the early phases, again, once I teach somebody how to use it, then I can't do it for them. They just need to actually do it. So I think after A, realizing it was possible, then actually seeing how it worked for people, and the feedback in terms of this has been, I don't know if I could have gone to a clinic and been as successful because eventually what happens in early post-op is it just fits into your gym schedule. And so naturally, the people that do really, really well with this type of setup, they're consistent. They communicate with us regularly and well so that we know how to, manipulate the program based on where they're at life-wise, because life will throw stuff at you. And they're already engaged in some sort of regular physical activity and or the gym, because essentially then they just plug and play and we take care of what they're doing in the gym. So that has been essentially, if I were to describe it simply, that's kind of how it has evolved. And then when we get to later stages, especially for a field or a court sport athlete, they have sessions programmed that are on a field or on a court and they have drills to do. We totally recognize and tell them that this is not reactive. Essentially, we eventually need to do this phase of some predicted stuff before then either adding a partner and doing some reactive stuff or having you have some modified participation with other people in a team. And again, that was another piece that I wasn't able to do in the clinic because I can't, like, liability and legality wise, go to a field with someone on the company's time in case anything were to happen. So in these situations, again, I recognize they're signing off liability waivers. This is coaching. This is not like, we're not billing codes, things like that. So I recognize that's an advantage there because people have the understanding going in. But for the right people and the people that are kind of, bought into the process, they do really well, oftentimes better than potentially they would have done in just a regular clinic.
Quick break because if you're a rehab professional sick of burnout, this could be your answer. Engage Movement's blended practice model is a proven system built by Dr. Ray Gorman, a PT who walked away from the 55-hour-a-week grind and built a blended practice model that doubled his income while working less than 25 hours a week, and he didn't have to rely on the traditional way of selling sessions to do so. It's all about blending remote and in-person services, stacking monthly recurring revenue, and building a business that finally supports your life, not the other way around. This model isn't just theory. Real providers, including myself, are creating lives of freedom and flexibility without being tied to their schedule. And as a listener, you get free access to the complete training. DM my name, Dan, to @RayGormanDPT on Instagram and receive your free breakdown on the model. Yeah, it sounds like this removes a lot of the barriers that we mentioned earlier, and it kind of provides the individual who's faced the injury that way with almost like a guide along their journey that way. And I think that's essential to note is, when I first graduated school, I looked at ACL rehab and I was like, oh, I have to do all these things and I've got to do X, Y, and Z and yada, yada, yada. And it's like, no, in reality, I just have to act as kind of like the Google Maps steering someone along the journey. It's not me doing the work. Ultimately, if you're the patient going through this, you have to put the work in yourself, and you just need someone to show you what to do, what not to do, how much to do, and kind of answer those questions and guide you along the path. And to the point you made about the communication, I think that is so, so undervalued, how important communication and just overall support is in this process because, as you mentioned, when you face an injury like this, part of your identity is kind of pulled from you. Maybe you like going to the gym and now you're not able to go to the gym and do all the things that you like to do, or maybe you're not able to go to the field and play sport the same way that you were not that long ago. And I think the more that you're able to kind of lean into and tap into those support systems and the more available they are to you, the better off your outcome is going to be. And I think that's where it also helps having, the ability to work with someone who has done this for, years and years and years, helped hundreds of other people because they get this experience and notice common trends with other athletes, or they see things that have worked for other people that they can kind of like guide you with. Or one of the things I'll do with people is if they're really struggling, I'll reach out to some of my former patients and ask them, hey, look, I know you're busy, but would you mind giving 20 minutes just jumping on a phone call with this person and talking with them a little bit about what you went through, what your journey looked like? And that was a huge motivating factor to even just bring athletes on the podcast and kind of shed some light on this space of, whatever, hard times that you're facing in your rehab journey. Know that you're not alone. Know that other people are there. It does get dark sometimes. It does get really challenging sometimes, but know that you're able to push through it. But to your point on the communication, again, I think that is so undervalued and underutilized in this. And I just really like that process of giving the person the autonomy to go at it kind of, independently a little bit, but with the guidance and the guide rails up so that they know where to turn, how fast to go, and so on that way.
Yeah, I would say that that is, and it's always been a strong bias of mine, the trying to understand, but also shout from the rooftops whenever I can about the psychological impact of this injury. It's crazy to me that it's still like, it's talked about in research. There's some pretty robust research to support its impacts, even on both the long-term outcomes in terms of return to sport rates, like you talked about it being super low. The psych side is a big part of, we think, okay, people just aren't getting strong enough or, but I mean, I am the poster child. I did not return to my sport because I was literally too scared. And there's no reason that I shouldn't have. I was 17. You know what I mean? Like and I think all the time about how many people out there are like me, had my situation where had they had different guidance, what could their athletic careers have looked like? And so I don't want, part of what I'm hell bent on is like, I don't want that situation to be the reality for anybody that we work with. Or at least like, it is possible sometimes with complications or whatnot that there might have to be a slight lower level of return, but that they should still be able to return. All to say, the communication piece has allowed, I've found, in terms of there's technically been a higher frequency, sometimes even a little bit of a deeper level of communication virtually, which sounds backwards, but it that's been a pleasant, like good surprise for me in this medium. And it has allowed me and us to pick up on some things mentally that I don't, mentally, nutritionally. It's another passion of mine in terms of like relative energy deficiency in sport with a lot of the younger female athletes that I have seen and do see. I just, I've been really, again, pleasantly surprised. Not that you want to come across things that are, on the darker side of things, but it does happen. This injury changes your life. It's not an exaggeration. So I do feel as though the kind of more frequent touch points that we've actually had, like asynchronously or virtually, has allowed us to pick up on some more things. This allowed me to refer out to sports psychology, register or sports dietitian. And honestly, again, I know it comes with being able to afford and to have access to those things, but a lot of times it's a lot more affordable than people think, especially in true necessity. So, it's resulted in adding potential other team members to this person's recovery that I think could really make or break their outcomes, and that feels good too.
Yeah, making it more interdisciplinary in nature. And it's so interesting that we call this field physical therapy because, as you alluded to, a lot of the times it's not just physical in nature. And I'm just like you, looking for other individuals to kind of get involved in the care of the person that I'm working with that way. And going back to what we talked about earlier and the importance of, if you're a patient or an athlete who's faced one of these injuries that way, don't be afraid to get the second opinion. Don't be afraid to interview your rehab providers and all that way, but also build a team around you, build your team, not just of your PT and your surgeon, but, if you're at a university or a school that way, don't be afraid to get your AT involved. In fact, please get your AT involved. I will always advocate for that. Get your strength coach on board. See who else you have access to. If you're on campus, again, you might have access to a dietitian already. You might have access to sports psych or chiropractic or some of these other disciplines already. And if not, kind of go about thinking about it. What pieces to this puzzle might I need and where can they come from? Can I find these people through the power of the internet? Can I find some of these people in person? What makes the most sense to you? And again, you can leverage the conversations or the experiences of other people because if there's one thing I've found, everyone knows someone who's torn their ACL. So don't be afraid to reach out to those people. Ask them questions. What went well? What didn't go well? What might you consider doing differently if it was to happen again that way? And try and leverage that as a learning opportunity for yourself to make sure that, again, if you're unfortunate enough to face one of these injuries, that you get it right the first time around. But, again, I just cannot emphasize enough that importance of building that team of people around you and having your support group built up as well to kind of help you through any kind of challenges and obstacles that might come up that way. And it sounds like from your own personal experience, Steph, there was challenges and obstacles that came about for you. And it's one of those things now that it's got to be so empowering and impactful for you to be able to take what has happened to you and turn around and make sure that it doesn't happen to anyone else in this quote unquote next generation, if you will.
Yeah, there's certain things that are totally out of my control and some people's, personal control with their injury, like anything else. But one thing that they will not have happen if they work with me or us is, you know, not feeling supported, feeling a little bit lost in terms of like where they are, where they should be going. Like those are things that are built into my being, our systems. I recognize I'm one person in a small team, and definitely, in my lifetime hope to have a bigger impact in some way, but like, at the very least, at the end of the day, that's what I can guarantee that it's not going to be a situation like it was for me. And that being said, there's also a lot of people that we get kind of coming to us later on. Like, let's say it was me at age 19 instead of 17 and like still probably in the window where I could have made some significant progress. But those options just didn't exist. And so those are sometimes just as fulfilling because people are at a stage where they've kind of given up or kind of like written off any possibility of getting back to this activity or, they've already kind of settled to not doing a sport, which depending on the situation, I may or may not agree with, depending on what they have going on at that point, like that far out. But I am a very strong believer that it's almost never too late in terms of making some significant progress with the right guidance. And essentially, again, I would be a good example of that in terms of it was probably 10 years later for me that I even kind of like really got into and like regular heavier strength training, like, and that has made the world of difference. I would be at very high risk going back to basketball right now. However, like I do most of the things that I want to do. I run, I lift, I can be active and agile with my nieces and nephews. Like, if I really wanted to play in like a chill adult league, I probably could, like nothing crazy. But yeah, it's always kind of at my core in the back of my mind with whoever I work with. And again, I recognize that that's potentially an advantage or a way that I'm able to really connect well with people. Um, but I wouldn't use it any other way. So
No, 100%. Ultimately, we take what has happened to us and use it as a way to, again, empower others and better their own lives that way. And I realized that the ACL and complex knee injuries and really just sports rehab in general is something that you're extremely passionate about. And I know that you and I can talk about it all day long that way. We could go on for another hour or two and still not even cover everything that there is in this space that way. But I also realized that you have so many incredible resources and offerings, and you help people, that are facing these injuries every single day, day in and day out that way. So for people who want to learn more and find more that way, where can they find more about you at online and so on that way?
yeah, definitely. So I admittedly like true millennial, so I never really got into TikTok or Twitter, although Twitter X, whatever, I don't really know what it's called. However, I am most usually on comfortable with and active on Instagram, stephallen.dpt end of last year. Only took 3 years into business, but I actually created a website. So that's just ACLResolve.com. That has a lot more information in terms of our team, kind of, you know, core values, philosophy, a little bit of information in terms of how we got started or what we offer, pricing, all that kind of stuff. So a lot of times people will start there because it's a little easier. And yeah, I know we didn't really talk much about it, but also a lead mentor and co-founder for Clinical Athlete, which is kind of, we talked about raising the floor in ACL rehab. Essentially, that's my husband and I and a couple of other co-founders, our other sort of life passion is just generally raising the floor in physical therapy in general. And so we do some mentoring for clinicians and coaches, and hoping to kind of build that up over the next couple of years and make an impact there. And that's just Clinical Athlete on Instagram as well.
Yeah, that's incredible work. And, it's so great that you bring that up because I think everyone, I don't care what, subset of PT you work in, I feel like everyone needs some kind of mentor or coach or someone that they can lean on themselves that way because there's always going to be a case that doesn't go like you expect it will or doesn't just present like the book said it would. And
Yeah.
you get a little confused when that happens. And it's nice to have someone that you can go to for an outside perspective and just as we mentioned, it's important for the patient to build up their own team around them. It's just as important, if not more important, for the clinician to do the same thing because, again, no one knows everything. So when things just don't sit right with you, you get that gut feeling. It's nice to know who you're going to turn to and have some kind of curriculum too to kind of guide you towards that higher status as a clinician that way and kind of learn more because as I'm sure all of us know, the knowledge is advancing far faster than I can keep up most of the time.
Yeah. Yeah, absolutely. And we're very principles based, not necessarily methods. So the methods are many, right? Like you guys use ISOFIT, which is like, but again, in order to effectively use something like the ISOFIT devices, which are great, you need to have the understanding of how isometrics work, how they fit into a strength training program, and all of those are principles based clinical
Yes.
reasoning. And so that's again where we at least feel like this is no knock on schools or curriculum. They have to fit so much in, but we're never really able to kind of go the layer deeper in terms of why are we doing things? Why do I make these decisions? What is impacting these? What do I want? What KPIs would I test? How does this, fit into programming? Because essentially we are for at least and I will clarify this, like in the ortho world, in the general, like kind of sports ortho PT world, we are like coaches. And so, in terms of, especially with potentially seeing people less frequently because of insurance restrictions, like we need to have a kind of grander plan or program for most people. Um, and that's just not something it's not something we get in school.
I love that point so much. It's not just the methods, it's about the underlying principles that guide and shape those decisions in the first place. And it's so interesting because I see a lot of people debating the methods, but really doesn't matter a lot of the
A
time. I'll
lot of
be
them
honest.
work.
Like there's 20 different ways to do the same thing. Pick
Right.
one that you like, get the results, understand the principles, and it's going to take you far. So I love that point, Steph. I really appreciate your time. I know you're a crazy busy person with so much going on all the time that way. I just really appreciate your time and the insights that you're able to share with us that way. I'm looking forward to future conversations with you.
Yeah, for sure. Thank you for having me, Dan. This was fun.